Good morning, everybody, and welcome to American Safety Programs and Training. Chapter Review, Chapter 19, Endocrine and Hematologic Emergencies. So, basically what this chapter is really going to discuss, in the majority of it, is going to be diabetes. But it's going to talk in depth about the systems and the organs that are used in the body, how the body works, how it processes the fuel, which is glucose, and what happens when the body has too much or too little, and what it does to try to function under each case. So, endocrine system. We're going to talk about the endocrine system and what it is. We're going to talk about its anatomy and physiology. Okay, the physiology. The pathophysiology is what they refer to is what it does, how it does it, and specifically we'll be talking about insulin today. We're going to talk about diabetes. What is diabetes? There are diabetes 1, diabetes type 2, and there's gestational diabetes. We're going to talk about how you assess a patient on a diabetic emergency call. We're going to talk about how do you care for a patient in a diabetic emergency medical care call. We're going to talk about some medications. We're going to talk about the 5 R's that you need to know about the medication. We're going to briefly discuss hypo and hyperglycemic, that's low and high blood sugar. We're going to talk about hematology, which is the study of blood and its diseases. And we're going to briefly review the ingredients of blood. What are the 4 things that make up blood? Okay, so first of all, let's start with endocrine. The endocrine system is basically a collection. Let me pull on the slide. Sorry about that. The endocrine system influences nearly every cell, organ, and bodily function. The endocrine disorders can have many signs and symptoms. Okay, hematologic emergencies, which are blood emergencies, are difficult to assess and treat, and our actions can actually save a life. So, endocrine system. The endocrine system is a collection of glands that produce hormones which regulate a wide variety of things. They regulate growth and development of the human body, tissue function, sexual functions, reproduction. It regulates our sleep, our mood, and many, many other things. Okay? The pancreas. The pancreas is the organ that actually makes the hormones. Okay? Let's talk about the anatomy and physiology. As we said earlier, the endocrine system is basically the communication system within the body that communicates between all the other systems, enabling the body to stay within the state of homeostasis. Just like a finely tuned car engine, or a finely tuned team like the Patriots. If everybody and everything is doing its part correctly, properly, on time, and the way it's supposed to, everything runs beautifully. When that happens with the human body, our body is in what we call homeostasis. Everything's perfect, fine. Everything's perfectly. Okay? So, let's see, the endocrine system is a communication system that controls functions inside the body, yes. The endocrine glands secrete messenger hormones, and endocrine disorders are caused by an internal communication problem. That is correct. So let's take into that a little bit more detail. So we know what the endocrine system is. It's basically, the endocrine system is a communication system between the collection of all the glands that produce hormones that regulate our growth and development, our tissue functions, our sexual functions, our reproduction, sleep, along with a lot of other things. Okay? If those systems are working and everybody's talking to each other, then we're in homeostasis. So it says it's glands. It's a collection of glands. The endocrine glands secrete messenger hormones, which are chemical substances that are created by the pancreas. Okay? They're hormones. These hormones travel through the bloodstream to their intended organ or the tissue it's supposed to go to, or to the cell, and it gives the message to that cell or that organ or that intended tissue. And once the message has been received, then we have to wait for the cellular process to take place. Okay? As I said earlier, the endocrine disorders are caused by an internal communication problem. For some reason, messages aren't getting out, or they're getting out but very slowly, or they're getting out way too fast. Could be that the receiving organ, tissue, or cell is feeling overwhelmed and it can't process the messages that quickly. Or it could be that it's hungry and it wants to process even more messages, but they're not coming fast enough. It could be that it just can't. Something's blocking its ability to receive that message. Okay? If the gland is not functioning properly, it might over or underproduce the hormones. Okay? If it underproduces it, the hormone is called hyposecretion, and if it overproduces, it produces too much of it, then that's called hypersecretion. Okay? Or if the gland or the tissue or the cell isn't working or responding correctly, then the desired response or the desired effect is not achieved. Okay? In order for us to function, our brain needs lots of things. But three of the most important things that it needs, or two of the most important things that it needs, is that it needs blood and it needs glucose. As we know, glucose is the fuel for our body. It's the gasoline that's in the tank. Okay, the gasoline goes into the engine, the combustion engine, a spark happens, it explodes. The explosion is controlled, making the piston go up and down, turning the engine, turning all these wheels, and that's what makes the engine work. Okay, with the human body, the brain is the controlling factor. Okay, it needs the blood, the O2, and the glucose. Okay, well, it needs the blood because in the blood is the glucose. Okay, the glucose travels within the bloodstream and it goes where it's needed. It needs O2, as we already know, because we talked about strokes and heart attacks and how our body needs perfusion and diffusion. So every inch of the body needs the oxygen, and the oxygen gets to the brain through the blood because it hops onto the hemoglobin and the red blood cells. Okay? So we have all this fuel in our body. We eat food, we digest it, it turns into glucose. Where does it go? Does it just float around in our body until it's used, until it's determined where it needs to be used at? And then it just goes to the toe or goes to the elbow or the shoulder or the abdomen or the skin or the organ or the cell in the stomach or the lungs or the adrenal glands or something? Yes, that's exactly what it does. But it doesn't know where to go until it's told where to go. Okay, and that's where the endocrine system comes in. Okay, so insulin is the key. Our body produces insulin. Okay, let me back up a little bit. This chapter is so full of information. I want to make sure I explain to you guys in a very logical order. So you have the pancreas. The pancreas is about in the middle of the body. It's up near the diaphragm, just below the diaphragm, and it goes from the upper right to the upper left quadrant. Okay. Now the pancreas is an organ that produces insulin and glucagon. Okay, insulin and glucagon are the two hormones that are produced by the pancreas. Okay, insulin basically, how can I say this? Insulin is the key that allows the cells to absorb the glucose, which in turn, when the cell eats the glucose, it produces energy and heat, and that's where we get our energy from. Okay? Mm-hmm. Glucagon is a hormone that helps us enjoy the benefits of the energy that is created when the glucose is absorbed by the cell. Okay? When we're talking about the pancreas, I said the pancreas is an organ that creates insulin and glucagon. Okay? A small portion of the pancreas is filled with two things they're called islets and Langerhans. Okay? The portion of the pancreas that is filled with the islets and Langerhans is about 1 or 2% of the pancreas storage space. Okay? that portion, that 1 or 2% of the pancreas, actually processes about 10 to 15% of the blood flow that goes through that organ. Okay, so the islets actually produce two things. They have alpha cells and beta cells. Alpha cells produce glucagon, which is the fuel, and beta cells actually produce the insulin itself. Okay, glucose is stored in the body. It can be stored in the liver as glycogen, and it's also stored in the skeletal muscles, and all of which are released at a time when the body needs it. Okay, as I said earlier, insulin is a hormone. Okay, glucagon. Okay, glucagon is a hormone that. Let's see, how can I say this? Glucagon is a hormone which controls our blood sugar. It stimulates the conversation. Or I'm sorry, it stimulates the conversion. It stimulates the conversion of glycogen, which is in the liver, into glucose, which can then be released into the bloodstream and thus consumed by the cells as food, creating energy. Okay. So the endocrine system is a communication system that controls functions inside the body. The endocrine glands secrete messenger hormones, okay, which is the insulin and the glucagon. And the endocrine disorders can cause internal communication problem. Glucose metabolism. The brain needs glucose and oxygen. Insulin is necessary for glucose to enter the cells. Each cell has doors on it. And in order for the glucose to enter the cell and to be consumed and create energy, the doors or the locks have to be unlocked and they have to be opened. That's what insulin does. Insulin allows the cells, or it allows the doors to be unlocked and opened, thus allowing the glucose into the cells to be eaten and create energy. The pancreas produces glucagon and insulin. It secretes insulin and the glucagon in response to the blood glucose level. Okay. Diabetes. Diabetes is a disorder of glucose metabolism. The body basically has a problem, which is an impaired ability to get the glucose into the cells to be used as a fuel. Patients either have an impaired production or they don't have enough receptors on the cells to allow the glucose in. Now, there's two things we're going to always deal with when they're in the field. We're going to deal with people who have high glucose levels and low glucose levels. High glucose level is called hyper. Hyper meaning high, fast, a lot of. Hyperglucose or hyperglycemia. Okay, and we have hypoglycemia. When somebody has too much sugar in their body and they can't process it, it can cause coma, death. It can cause blindness, kidney, and heart disease. Okay, the person is going to present being very, very tired. They're going to be peeing a lot. They're going to be dehydrated. They're going to have an increased thirst. And people with low blood glucose can experience blurred vision. And they can have dementia. They have a higher chance of falling because they have an altered mental status. In the process of falling, they have a higher chance of getting fractures, and they have a higher chance of heart attacks. Okay? You need to know the signs and symptoms of blood glucose, which is high hyperglycemia, low hypoglycemia. Hyperglycemia and hypoglycemia can occur with diabetes type 1 and diabetes type 2. And I'll get to presenting those two in just a minute. All hypoglycemic patients require prompt treatment. Somebody who has hyperglycemia or somebody who is hyperglycemic means that they have a high amount of sugar in their body. That usually takes a long time to build up. That can take days and weeks. Whereas somebody who has hypoglycemia, which is low blood sugar, that is an immediate threat. That means that your engine is sputtering, it's running out of fuel, and you don't want the car to break down and to stop running in the middle of the expressway. Well, just like the human body, you don't want it to stop working because it doesn't have enough fuel, which is the glucose. So the emergency situation is we need to try our best to identify whether the person is hyper or hypoglycemic. If they are hypoglycemic, the one thing we can do with that patient is that we can give them a medication that's called oral glucose, which we'll talk about in a minute. And by doing that, you're introducing sugar into their system in a way that will allow it to be quickly dissolved and put into the bloodstream, thus absorbed by the cells, thus giving them energy and making the person feel better, and bringing them out of the altered mental status. So, okay. Let me see here. So when you're taking care of a patient and you do a BGL check, it's a blood glucose level. You're going to use a portable glucometer. You prick their skin on their finger. First of all, you clean the skin with an alcohol wipe. You let it dry. You poke it with a small little point of a needle. A little drop comes out. You're going to put that drop of blood on the glucometer stick, and it's going to be absorbed into the machine, and it's going to measure the amount of sugar in it. The normal average blood sugar for a healthy adult is anywhere between 80 and 120. 80, 85, 90, 95, 100, 110, 120. Anywhere between 80 to 120 is considered average blood sugar level in a person. When a person blood sugar level goes above 120, they are considered hyperglycemic, or they're considered hyperglycemia. When a person goes below 80, they're considered hypoglycemia. Okay? Whenever you have a patient who has altered mental status, they're just not acting right, you always do a BGL, a blood glucose level on them, because you don't know if they've got high sugar or low sugar. Okay? And if they have low blood sugar and they're not able to talk to you that much, by finding out that if they have a low BGL in the 50s or 60s, that might be the issue right there. That may be the foundation of all the problems that they're going through, and that's the reason why they called. Okay? That's why a hypoglycemic patient requires prompt treatment, because somebody who's hypoglycemia, they can die within a couple of hours if it's not treated immediately. Okay? Diabetes 1, or diabetes mellitus type 1. It's an autoimmune disorder where the immune system produces antibodies that attack the pancreatic beta cells. Okay? Now, if you remember, I had mentioned earlier, I apologize, let me go back to my notes. The pancreas has a storage area, or a little production area that's 1 or 2% of the, takes 1 or 2% of the pancreas portion, and it has islets and Langerhans. Those islets, I-S-L-E-T-S, islets, produce alpha cells and beta cells. The alpha cells produce the glucagon, and the beta cells produce the insulin. Okay? So it was an autoimmune disorder, which means your immune system, the one that fights infection and stuff like that, the one that puts you in an anaphylactic shock because it's an over-exaggeration of an outside stimulus. Okay? It actually creates antibodies that goes against the pancreatic beta cells. And don't forget, the beta cells are what produce insulin. Insulin is the hormone that helps the cells, that unlocks the cells so the glucose can get inside of it. So if the beta cells are not allowing the glucose to get into the cell, that means you're going to have low blood sugar. Okay, missing the pancreatic hormone insulin. Okay, onset usually happens from early childhood through the 4th decade of life, which basically means it develops in early childhood, and most people, they have it through their 40s. Okay, a patient must obtain insulin from an external source. Because the body is being attacked by its own immune system, okay, whatever insulin is created, it is destroyed, and the production level is destroyed because of the body's immune system. So the person doesn't have enough insulin in the body. Not enough insulin not enough keys to unlock the cells to let the glucose in. So that's why people who are type 1 diabetes, they have to take insulin every day. They have to take a reading before they eat, what their sugar level is, and then they base the amount of insulin off of what their sugar is at the time that they're going to eat, and also what they're eating as well. That's why people who are type 1 diabetes, they have to be very careful what they eat. Okay? Let me see here, what's next? Many people with type 1 diabetes have an implanted insulin pump. It's very common for someone. It's an insulin pump. They either put it on the belt of their pants or they have a strap and it's strapped to their abdomen. And it's a little itty bitty tube that goes right into their abdomen. Okay? And the pump is constantly going. It's not always pumping insulin into their body, but it's constantly measuring 24/7, 365. It's constantly monitoring the sugar level in the patient's body, and if it senses that the sugar is too low, then it will put a little bit more insulin into the body to let the sugar be absorbed by the cells. Okay? It continuously measures glucose levels and provides an adjustable infusion of insulin in the body when needed. It can malfunction and diabetic emergencies can develop. People who have an insulin pump know their body better than anybody else. They even know it better than a diabetic doctor, a specialist. So if they tell you they need to go to the hospital, they need to go to the hospital. If they call you, they're calling you because they know something's not right. Okay? Always inquire about the presence of an insulin pump. If they have an insulin pump, they're your best source of information. How long have you had it? How often, did you change the insulin? Could it be out of insulin? What do you think's wrong with it? Did you change the batteries? They can tell you exactly what's going on. Okay? Diabetes mellitus type 1 is the most common metabolic disease of childhood. Okay? New onset patient symptoms are going to have polyuria, polydyspia, polyphagia, weight loss, and fatigue. Okay? Now, you might want to say to yourself, what is polyuria, polyphagia, polydyspia? Polyuria, okay, is a lot of peeing. You urinate a lot. Okay? Polydyspia is excessive thirst. You're always thirsty. Polyphagia is excessive eating. Okay? Weight loss and fatigue. Okay? So, make sure I get this straight. Okay, so let's go back. So polyuria is excessive urination. Polydyspia is excessive thirst. Polyphagia is excessive eating. And you've got weight loss and fatigue. Okay? So, quick recap of diabetes 1. It's the body's autoimmune system produces antibodies that go against the pancreatic beta cells. Therefore, the body doesn't make enough insulin. Okay, that's why people have to have insulin pumps. That's why they take insulin. You can't take insulin as an oral medication. They don't even make it because when you take insulin as an oral medication, the insulin dies. It doesn't survive. That's why people have to have insulin injected into their bodies. Okay? Diabetes 1, as we said, usually develops in early childhood and lasts into the person's fourth decade of life, which is their 40s. The person is going to experience increased urination, thirst, excessive eating. They're going to have late weight loss and an increased level of fatigue. Okay? The kidney does filter blood and doesn't affect, as you know, the kidney filters the blood, but the amount of sugar that's in the kidneys doesn't affect the filtration. But with the increased glucose in the blood, the excessive glucose spills over into the urine. What that means is that your body can only have so much glucose in it. As the glucose starts to increase and increase and increase, and your body's not making enough insulin to let that glucose into the cells. Okay, see if you can follow me. So, your kidneys filters the blood. Your blood can only have so much sugar in it before it really starts to affect you. So, because your body is not creating enough insulin, and as you know, insulin is the key that lets the glucose into the cells, which give us energy. Because the body has hindered the pancreas's ability to make insulin, You've got all the sugar in your system, and your body just can't absorb it. The food's there, but it can't eat it. So the sugar level keeps increasing and increasing. Your body says, "Whoa, I can't have this much sugar in my body." So what it's going to do is, as the blood is being filtered through the kidney is going to say, "Whoa, too much sugar. I got to get rid of some of this sugar." So it's going to take that sugar and it's going to divert some of the sugar to go into your pee, and you're going to try to pee out that excessive sugar. Okay. The reason why you're going to have increased thirst is because you're going to be peeing so much. Your body's trying to get rid of the excess sugar. So it says, okay, we need to urinate a lot more. So we need to drink more liquid to try to get it out. Okay, but the body just can't keep up with that. Okay, so what it's going to do is, so it diverts a lot of the excessive sugar into your urine. It's going to make you pee a lot. In this process of making you pee a lot, you're going to be thirsty a lot to replace all the fluids that you're urinating out. So you're going to be drinking a lot. Okay. You're going to have decreased weight. You're going to have excessive eating because your body says, we need more energy. Well, it's got all the energy it possibly could want because it's in the blood, but it can't be absorbed because there's not enough insulin in the body. So the body's going to say, eat more. We need more energy. Because the sugar is not being absorbed into the body, you're going to start losing weight. And because you don't have the energy, because the cells can't absorb the glucose, you're going to start feeling really tired. You're going to get really fatigued. Okay. And as a backup, like the kidneys can only divert so much of that extra glucose in your body into your urine to help get rid of it, but that it can't do it all. So as a backup system to help the kidneys out, the body's going to start burning fat for energy. Okay? And a byproduct of burning fat is what we call acid waste. Okay? Or the byproduct is acid waste. Okay? And we call the acid waste ketones. Okay? So what the body's going to try to do is, as it's trying to burn the body fat to help get rid of the excess sugar, because it's going to burn the fat that you have stored in your body for energy because it can't absorb the glucose that's in the bloodstream. It's going to create a byproduct of that fat burning, which is acid waste. It's going to increase your pH balance in your body, and that acid waste is what we call ketones. So another way that your body can help the kidneys out is that it's going to have you start exhaling. It's going to increase your respirations, and it's going to have you take deeper breaths. So you're going to take deeper breaths, and they're going to be a lot faster in an attempt to breathe off those ketones. Okay? And when you breathe off those ketones, your breath is going to have this fruity, sweet smell to it. And a lot of people who have ever dealt with somebody who's intoxicated, when they're talking to you and they get close to your face and you can smell their breath, it smells sweet because of the alcohol, because of the sugar that's in the alcohol. Well, in this case, the person's not drunk. They have high blood sugar. Okay, they're hyperglycemic, and their body's trying to get rid of it by burning body fat, creating acid waste, which is what we call ketones, and in making you breathe faster and take deeper breaths is going to create the fruity smell. Now, when you start to exhale faster and deeper, we call those Kussmaul respirations. Kussmaul respirations. Kussmaul respirations are a sign that the person is trying to get rid of a lot of ketones. Their breath is going to be fruity, and they're in a diabetic emergency. Okay? And the keystones, when a situation's in a spot where they've got the Kussmaul respirations going on, their breath smells very fruity because of the acid waste. We call that diabetic keystone acidosis. That's DKA. D is in Delta, K is in Kevin, A is in Alpha. Diabetic keystone acidosis. Okay? Patient's blood cholesterol, diabetes mellitus type 1 patient's blood glucose level is above normal. which is over 120, kidney's filtration system becomes overwhelmed and glucose spills into the urine. Glucose is unavailable to the cells. Body turns to burning fat, produces acid waste known as ketones. Kidneys cannot maintain acid-base balance. Kussmaul respirations result. If fat metabolism and ketone production continues, diabetic ketone acidosis, DKA, can develop. It may present as a generalized illness. They don't feel good. They don't know what's going on. DKA, diabetic ketone acidosis, can result in death. Obtain your patient's history and presentation. Obtain a BGL level. And usually somebody at this level, when you do a BGL, it's going to show that they're over 400. Okay? If they're, like I said, it's between 80 and 120. If somebody's at 180 or 200, they're not going to be in a life threat situation. But it's when the BGL gets up to 400, 450 and higher, that's when they're going to be in this situation, which is not good at all. Okay? So diabetes 2. So diabetes mellitus number 2 can be controlled by diet, exercise, and medication. Okay? The insulin receptors on the cells resist, and they don't unlock the door, allowing the glucose in to be eaten to create fuel. Okay, let's just say here, caused by reasons that affect the insulin cellular level, an association between obesity and increased resistance to the effects of insulin. Pancreas produces more insulin to make up for the increased levels of blood glucose and dysfunction of cellular insulin receptors. And insulin resistance can sometimes be improved by exercise and dietary modification, as well as oral medications as well. There are oral medications that a person can take. It's not insulin that they're taking, but there are oral medications out there like glipizide, glyburide, metformin, Januvia, and Avandia. The most common one, I used to work at CVS Pharmacy as a head pharmacy tech for years, and metformin is the most common one. Metformin actually helps regulate the amount of insulin that your pancreas generates. Not everybody is on these medications. One medication might work differently for somebody else. One might be more effective or least effective for somebody else. Diabetes is a disease. It's a medical condition that messes with your entire body. It messes with every cell, every organ, every tissue in your body from your head down to your toes. If you have a heart attack, that's affecting your heart. If you're having a stroke, that's affecting your brain. If you have an injury, you have a broken arm, that's affecting the bone and maybe the tissues around it. Okay? If you're sick, if you have the flu, that's going to affect, your body temperature and how you feel and all the other parts of the body that affects. But the flu doesn't affect every inch of your body. Diabetes affects every cell in your body, whether it's a cell on the top of your skin, under your skin, in your bones, everything. Diabetes affects everything, okay? Because diabetes messes with the organ that creates the hormones that our body needs to use the fuel that our body is given when we eat. And when that process of utilizing the fuel that we give our bodies, then the entire homeostasis thing is thrown out the window. So that's why some people will be on more medications than others. That's why it'll take a person a long time to get their diabetes under control, because they have to change their way of living. They have to change the way they eat, what they eat, when they eat, how they eat. They have to get the diet, the exercise down. They don't want to under-exercise. They don't want to over-exercise. It's playing a balancing game for their entire life. Okay? Let's see. So basically, long story short, diabetes mellitus 2. The receptors on the cell are resistant to absorb the insulin. The insulin comes and it knocks on the door of the cell, say, hey, let us in. I got the key. And the cell or the receptors are going to say, nope, you can't come in. Sorry. So it's the receptors on the cells that are the problem. So that's why the medications help those receptors do the job that they're supposed to do. So when the glucose comes, or I'm sorry, when the insulin comes, say, hey, glucose is here, insulin's here. Insulin says, I'm the key, let me unlock the door. Then the receptors say, okay, put the key in, unlock the door, and let the glucose in. Okay, that's basically what it is. Let's see, oral medications used to treat type 2 diabetes. Some increase secretion of insulin and pose a high risk of hypoglycemia reaction. Some stimulate receptors for insulin. Others decrease the effects of glucagon and decrease the release of glucose stored in the liver. And again, when glucose is stored in the liver, it's called glycogen. Okay, injectable medications and insulin are also used for type 2 diabetes. So people who are in type 1 diabetes is controlled with insulin. People who are type 2 diabetes control it with insulin and or oral medications in addition to diet, exercise, and those medications. Okay? Diabetes 2 is often diagnosed at your yearly medical checkup. The doctor is going to see that your BGL is constantly on the high side. They take your weight every time you go into the doctors. They're going to see that your weight keeps going higher and that you're obese or you're much heavier than you should be and you're not losing the weight. Okay? You might have a recurring infection that the doctor keeps looking at, because when you have diabetes, infections and injuries take a lot longer to heal. Okay? You can have a change in vision because of the glucose level and all the other systems in your body that aren't working correctly. It's going to affect your eyes. And you have numbness in the feet. Okay? It's very common for someone who's a diabetic and they don't control it. They have to amputate certain parts of your body, and it's usually the toes and the feet that go off first. I can't tell you the number of times I have gone into a nursing home to take a patient to dialysis treatment or take them to the doctor's office, and they have diabetes and they've had it for years and it's uncontrolled, or they don't take care of themselves, and it comes to the point where it affects the cells down in the lower extremities. And those cells, because they're just not getting everything that they need to survive, the skin and the tissue start to die. And then it turns black, it turns green, and they've got to cut out the toes, and they've got to cut out the foot, then they've got to cut out the leg, they've got to cut off fingers. And it's all because they have uncontrolled diabetes. They don't take care of themselves. Okay? Symptomatic hyperglycemia occurs when blood glucose levels are too high. We know that. Patients are in a state of altered mental status resulting from several combined problems. Type 1 diabetes leads to ketone acidosis with dehydration from excessive urination, like I said. And type 2 diabetes leads to non-kinetic hypermolar state of dehydration. Type 2 diabetes leads to non-ketotic hyperosmolar state of dehydration. That's a tongue twister. So what is hypersmolar hyperglycemic non-ketonic syndrome, otherwise known as HHNS? It's when the blood glucose levels are not controlled in diabetes mellitus number 2. Key signs and symptoms. Okay. Higher glucose levels in the blood cause excretion of glucose into the urine, just like in type 1. Patients increase fluid intake, just like type 1. Patients cannot drink enough fluid to keep up with the extremely high glucose levels in the blood, just like type 1. Urine becomes dark and concentrated, okay, just like in type 1. And patient may become unconscious or have seizure activity due to severe dehydration, just in type 1. So type 1 and type 2, a lot of the key signs and symptoms are very, very similar. That's why they say it's very difficult to determine what's going on. But once you take a blood glucose level, if it's above 120 or it's in the 400, they're a hyperglycemic patient. They have too much sugar in the blood. If it's below 80, then you know that they're high. Then you know that they're hypoglycemic. Okay. In this case, symptomatic hyperglycemia, which is what we're talking about, this is when glucose levels are higher than they should be. Okay. So that is symptomatic symptomatic hyperglycemia, high blood sugar. What about low blood sugar? Symptomatic hypoglycemia is an acute emergency where a patient's blood glucose level drops and must be corrected swiftly and quickly. It can occur in patients who inject insulin or use oral medications. When insulin levels remain high, glucose is rapidly taken out of the blood. If glucose levels fall, there may be an insufficient amount to supply the brain. What that means is that it can occur with people who take insulin by injection or people who take insulin by injection and oral medications. It can happen to either or people. Okay? Basically what it's also saying is when insulin levels remain high, glucose is rapidly taken out of the blood. So, insulin is the hormone that tells the cells, hey, I'm going to unlock you so you can absorb the glucose, right? So insulin is the key. So when you have a lot of insulin, when it says when insulin levels remain high, so when there's high levels of insulin, that means your blood is loaded with thousands of keys and it's unlocking all the cells. And the cells are eating way too fast, or eating way too much. And the amount of sugar that's supposed to be, the perfect level of sugar that's supposed to be in your bloodstream is going to be lower than it's supposed to be because there's too many keys. Your cells are gorging themselves on the amount of sugar that's in your bloodstream, and your bloodstream level of glucose is going to go down and down and down, and it's going to start running out of fuel. Okay? If the glucose levels fall too much, then there may be an insufficient amount of glucose. As we said, the two things that the brain needs is glucose and blood, and oxygen. If it's not sufficient amount of glucose for the brain to absorb and to use, because it's a supercomputer, it uses a lot of it, then you're going to have altered mental status. Okay, right there. Mental status declines. Patient may become aggressive or display unusual behavior. It is very common to see somebody who is hypoglycemic, and they become extremely irritable, and they become very violent. They become very aggressive towards the caretakers. And it's very common for someone who's 100 pounds soaking wet to be able to take out 2 full-size EMTs because they just get that aggressive. Unconsciousness or permanent brain damage can quickly follow. It is extremely important that once you identify somebody who is hypoglycemic, that you get sugar in their body immediately. Hypoglycemia develops more quickly than hyperglycemia. Hyperglycemia can develop over a couple of days or weeks. Hypoglycemia can develop within a couple of hours. Okay, what are the signs and symptoms of hypoglycemia? Lots of them. Let's go right here. Okay, right here. Hypoglycemia is quickly reversed by giving the patient glucose. You can see right there. You can see the 400 mark. That's DKA, diabetic ketone acidosis, and also the HHNS. That's when they get the Kurzweil respirations. Okay, under that is 120. Anywhere in between here is hyperglycemic. Anything above here is when you start to get into a life threat. Okay, you've got 100 to 80. This is normal. Anything below 80 is hypoglycemic, and anything under 40 is a hypoglycemic crisis. I've had people whose blood sugar is at 52, and they're trying to eat some ice cream or chocolate or candy to get some sugar in their body, and their hands are shaking uncontrollably, where they try to get the candy bar up to their mouth, and the candy bar is just flopping all over the place. They can't control their hand. They can lift the arm up with the candy bar, but they can't get the candy bar into their mouth. So, let's see. When you give, okay, so, did it say this? I think it did. So, some of the medications that we can give to a patient who are experiencing a diabetic emergency, especially when they're experiencing a hypoglycemic emergency, we can give them oral glucose, which is a gel. It's like, it's clear. It is clear cake frosting, basically. That's basically what it is. And you squeeze it into their mouth a little bit at a time, and you let them swallow it. You let them swirl it around in their mouth, and you let it slowly dissolve in their mouth. Sometimes you can take a tongue depressor, squeeze them on the edge of the tongue depressor, and stick in between their cheek and gums, and rub it up and down, back and forth. The mouth is very porous, so it will absorb that sugar very, very quickly. You're going to give them over time the entire tube of oral glucose. But before you give this glucose, you need to make sure that you call med control and tell them what you have and get permission from med control first. So there's oral glucose, which is the gel. There's chewable tablets, which are basically fruit-flavored sugar tablets. And then there's liquid sugar. In the field, in Rhode Island, we are only allowed to give glucose gel. We don't have chewable tablets or liquid on the trucks. Those are not in our protocols. Okay? So, when you're giving a medication to somebody, there are certain things you need to make sure that you do. Okay? You need to make sure that you're following the 5 R's of giving a medication. Okay? You need to make sure that you have the right person, the right route, the right time, the right med, the right dose, and the right documentation. I apologize. That's 6. You want to talk about the 6 R's. Okay? You want to make sure that the person you're going to give the medication to is a person who is hypoglycemic. You want to make sure that you're going to give the medication, you're going to give it by the right route, which in this case is going to be orally. You make sure you want to give it to them at the right time, that they're taking the medication when they should be. Okay? You want to make sure that it's the right medication. Are you going to give somebody aspirin who's a hypoglycemic patient? No, you're going to give them oral glucose. You're going to give them sugar. You want to make sure that you give them the correct amount, and you want to make sure that you document exactly what you gave them and when you gave it to them. Right documentation is key. Okay? Let me see here. Am I forgetting anything? I just want to make sure. The tube of glucose, in oral glucose, it normally comes in like a cherry or a lemon flavor, and it's a 15-gram tube. And like I said, it's like clear cake frosting. It's like a gel. Okay? A lot of times you're going to give somebody oral glucose, and they're going to start feeling a little bit better, and their level of consciousness is going to get better in about 10 or 15 minutes. And they may have been unable to barely talk to you before, but now they're going to be able to talk to you a little bit better. They're conscious. They have a gag reflex. They can swallow. So at that point in time, you might want to have one of your partners run into their kitchen, see if they have any orange juice or some fruit juice. If they've got some orange juice, pour some in a glass, put about 3 tablespoons of sugar in it, and go ahead and let them sip on that for a little bit. Get some more sugar. Orange juice is very high in sugar. Cranberry juice and grape juice is very high in sugar. You want to let them take little sips of that. That way they're getting the sugar into their system in a liquid form, that is very quickly absorbed into the body. And then as soon as they're stable, you want to get them to the hospital. Again, anybody who's experiencing a hypoglycemic or hyperglycemic incident, you want to get them to the hospital, because when these people are experiencing a hypo or hyperglycemic situation, they have altered mental status. And anybody with altered mental status, you want to get them to the hospital, because there could be a lot more going on than what you think or what you diagnosed. Okay? There could be the domino effect going on. Okay? So, when you are evaluating your patient, scene safety. Patients with diabetes may use syringes. Be aware that you're not going to stand or kneel on a syringe that's been used, a dirty syringe. Be alert for clues. Do you see the syringes? Do you see a small bottle of insulin next to them? Are there a bunch of candy bars near them? Big bottle of juice that they're trying to drink? Okay, use your standard precautions. Use your common sense. Question any bystanders on the events leading up to your arrival, or their caretaker, their spouse, their son, their daughter. Okay? Keep open the possibility that trauma may have occurred. It could be that an 86-year-old lady who is a diabetic isn't feeling that very well, so she wants to go into the kitchen at 4 o'clock in the morning and get herself a glass of orange juice, and she's been a diabetic all of her life. She knows herself better than anybody else. So she's walking into the kitchen, and all of a sudden she loses consciousness, or she loses her footing because she, number one, she's experiencing altered mental status, but she was able to get out of bed, walk into the kitchen, start to open up the refrigerator door, and because she's weak, she pulls on the door a little bit too hard, loses her footing, and falls down to the ground. Well, in the process of falling, her head may hit the corner of the kitchen table, or something that's in the kitchen. Husband hears the noise. He gets out of bed, walks in, finds her on the ground, unconscious. Okay, no major bleeding going on, but now she's not only a medical patient because she had low blood sugar, but now she's also a trauma patient because she struck her head while she was falling to the ground. Can you have a medical patient that turns into a trauma? Yes. Can you have a trauma that turns into a medical? It doesn't turn into, but the trauma could have been caused by the medical. Can you have a patient who's a medical and a trauma, or a trauma and a medical? Most definitely you can, because you don't know which one came first. Okay? Chances are usually if the person is hypoglycemic and there's a trauma, chances are usually pretty decent that the low blood sugar caused the trauma. Okay? You want to determine is it an MOI, mechanism of injury, or NOI, nature of illness. Get your general impression formed. Okay? Determine your level of consciousness. Level of consciousness. Are they alert to person, place, time, and event? Do they know who they are, where they are, what day of the week it is, what month it is? And do they know what happened? Do they know why you're there? Then you want to check your ABCs, airway, breathing, circulation. Is the airway secure or not? If it's not, you have to secure it. What are you going to use to secure it? An OPA or an NPA? If you're going to use one of those devices, how are you going to measure it? You measure an OPA from the corner of the mouth to the earlobe. You measure an NPA from the tip of the nose to the airway. To the earlobe. How do you insert an OPA, oropharyngeal airway? You're going to insert it upside down, turn it. When you feel resistance, you're going to turn it 180 degrees and continue to insert it into the mouth so it latches onto the back of the tongue, and you're going to let the end tip of the OPA rest on the patient's lips or their teeth. If you're going to use an NPA, okay, what side of the nose are you going to put it on? You're going to put it on the right side or the left side. If you put it on the right side, you know what to do. You take the beveled side, you lube it up with water-based lubricant. The bevel is facing the septum, and you stick it right in. And that's if you do on the right side of the nose. If you do on the patient's left side, you're going to insert it, again, lube it up with water-based lubricant. Bevel is facing the septum, which is the middle of the body. You're going to push it in about halfway until you meet resistance. Then you're going to turn that 180 degrees, same way you did with the OPA. Going to turn that, and then you're going to push it all the way down. So that when you have the NPA in, whether you have it completely in on the right side or completely in on the left side, the bevel of the NPA should be facing the left shoulder once it is completely inserted. Okay? Patients showing signs of inadequate breathing, a pulse oximetry less than or equal to 94%, or altered mental status should receive high flow oxygen, 12 to 15 liters per minute, non-breather mask. Okay? If I remember correctly, it's 10 to 15 liters on the airway chart that we gave you guys. Okay? Non-rebreather, 10 to 15 liters per minute. At 15 liters per minute, that person is getting what saturation of oxygen? They're getting 80 to 90% saturation of oxygen. Okay? So that's your airway and breathing. Okay? And if they're not breathing, and if they're breathing sufficiently, great. If they're not, are they breathing too slow? Are they breathing too fast? What's the average respiration for a normal healthy adult? It's 12 to 20. So if they're breathing less than 12, what do? Do you breathe for them? When do you breathe for them? If they're around 8 or less than 8 rest of minutes, you're gonna ventilate. If they're breathing too fast, if they're at 28 or higher, you're going to ventilate for them as well. So remember, less than 8, more than 28, ventilate. Airway breathing continued. Hyperglycemic patients may have Kussmaul respirations, a sweet, fruity breath. Okay? Sweet, fruity breath is not Kussmaul respirations. Sweet, fruity breath is based off of the ketones, the ketone acidosis, because the human body is beginning to burn fat for energy, and in the process of burning the fat, the waste product is acid waste, and it's called ketones. The Kussmaul respirations are when your body says, hey, breathe deep and breathe fast, in an attempt to breathe off those ketones. Okay, hypoglycemic patients will have normal, shallow, hypoglycemic patients will have normal or shallow to rapid respirations, anywhere in between. If they're respiratory distress, handle it. You know what to do. Circulatory status. Dry, warm skin is going to be for a hyperglycemic patient. Hypoglycemic, they're going to have moist, pale skin. A person in hypoglycemia emergency, that is a massive life threat. It comes on very quickly, and it's very dangerous. And if you take a look at the moist, pale skin, what does that resemble? What do you think that means? That could mean something else. Moist, pale skin. Remember, you're checking the skin color, temperature, condition when you're doing the circulation. When you're checking the circulation, you're checking for the pulse. Is it strong, steady? Is it slow? Is it fast? Is it thready? But when you're taking the pulse at the radial pulse, you're touching the skin. You're checking the color, and you're checking the skin's color, temperature, condition. If it's pale and moist, What does that mean? It could mean that they're going into possible shock. Okay? At this point, once you do the ABCs, then you make your transport decision. Is this a scoop and screw or a stay and play? Is the person in a life threat situation? I need to get into the hospital right away. That's when you want to get them on the stretcher and get them en route to the hospital as fast as you possibly can. Hopefully you've already called ALS to either meet you on scene or to intercept you. Okay, it could be either advanced or paramedic. Okay, or if the patient is not and their body is stable and they're not having breathing difficulties, their ABCs are good, strong, and normal, maybe a little bit out of the ordinary, but not a red flag going off, then you can spend a little bit more time taking care of the patient right then and there, asking them more questions. Okay, history taking. You know about the history, OPQRST sample, OPQRST onset, provocation, quality, radiation, severity, and time, and then sample, signs and symptoms, allergies, medications, past pertinent medical history, last oral intake, and events leading up to. Okay, onset. Did it come on slowly or quickly? P, do you have any pain? Do you experience any pain? Okay, OPQ, quality. If you are having pain, can you describe it to me? R, if you're having pain, radiation, is it going anywhere? And T, time, when did it start? When did everything start? Okay, sample, signs and symptoms. You're going to get a lot out of sample. Signs and symptoms. You know what a sign is what you see. A symptom is what the patient tells you. If they're conscious, they can tell you what's going on. Hopefully they're going to be aware enough where they can tell you what's going on. A, allergies. Do you have any allergies? M, medications. Well, I take metformin and I take, I have this insulin pump. What does that tell you right there? If the person takes insulin every day, they're a diabetic. If the person takes metformin, they're a diabetic. Okay? As you're in the field more and you get more exposed to different types of diabetic emergencies and you start to learn and you're going to hear the same medications being used over and over again, you'll begin to know what medications are used for what situations. Okay? Where was it? SAM. Okay, and medications. Okay? P, passport and medical history. So you're diabetic. How long have you been a diabetic? Oh, just diagnosed about 3 months ago. Okay, or I've been a diabetic for all my life. Person who's been a diabetic all their life, they know their body, they give you a lot more information. Person who's a recently diagnosed diabetic and they're taking the medication, it could be that they're still trying to get used to taking the medication and they maybe took too much, or they didn't take enough, or they took it at the wrong time. Maybe they didn't realize that they took their insulin but they forgot to eat. So they told the body, release stored sugar into our body, release the stored sugar that we have in our body because our body's going to need it, and it'll be replaced with I'm going to eat my meal now. But the person forgets to eat. So they're using up the stores of glucose that's in their body, but they're not replacing because you didn't eat. So when that sugar is absorbed and it's eaten, there's going to be no sugar left, or the sugar level in the body is going to be reduced, and the person is going to become hypoglycemic. Okay? If the patient is L, last oral intake, and E, events, what was going on? If a person's a diabetic, if they go to the gym or they did some work around the house, if they overexerted themselves, if they did too much work, they used up more sugar than what they expected to, they need to replace that sugar right away. They go to the gym, they work out and stuff like that, they want to stay healthy, they want to stay in shape. As soon as they're done at the gym, they need to replace that. So they're probably going to go to the bar that a lot of these places have, and they'll get a power drink, or they'll get a smoothie, a fruit smoothie with the sugar in it. Or they might have a fruit bar or something like that in their car, in their gym bag that they're going to start to eat, because they know they just used a lot of energy, they used a lot of glucose, so they need to get it replaced. So they have a backup plan. They know what they need to do. Okay? If the patient has eaten but not taken insulin, hypoglycemia is more likely. If the patient has taken insulin but not eaten, hypoglycemia is more likely. If the patient has eaten but not taken the insulin, or if the patient has taken the insulin but not eaten. Carefully observe for signs and symptoms to determine whether the person is hypo or hyper. Okay? Sample, you know what to do. Signs and symptoms sample. Did you take an insulin or pills to lower blood sugar? Do you wear an insulin pump? Have you taken your usual insulin dose or pills today? Have you eaten normally today? Have you had any illnesses, unusual amount of activity or stress? Okay? Then after the history, you're going to do your secondary exam. The secondary exam is when you concentrate on the affected body part or body system. Okay? Assess the unresponsive patient from head to toe. Okay? When you suspect a diabetes-related problem, focus on mental status, ability to swallow, whether they have a gag reflex or not, and an ability to protect the airway. If they can't protect the airway, it's not patent. Then you need to secure that airway. If they can swallow, great. Then maybe the gag reflex will be strong enough where we can get some oral glucose into their body, okay, and obtain a Glasgow Coma scale score, okay. Vital signs: blood pressure, pulse, respirations, okay, neural check, lung sounds, and a BGL, blood glucose level. Use a glucometer if available and protocols allow. Okay, in Rhode Island, you're definitely allowed to do it. Hypoglycemia. Respirations are normal to rapid, pulse is weak and rapid, and skin is typically pale and clammy with a low blood pressure. Signs of shock. Hyperglycemia. Respirations may be deep and rapid, Kussmaul respirations. Pulse may be rapid or weak and thready, and skin may be warm and dry with a normal blood pressure. That's, if you take a look at the last two, skin condition. Someone who's hypoglycemic is going to have cool, clammy skin. Somebody who's hyperglycemic is going to have warm, dry with warm and dry. Okay? Portable glucometer. Study the operator's manual for proper use. Know the upper and lower ranges at which your glucometer functions. Some glucometers, if it can read up to a BGL of 500, anything over 500, it just says high. Okay, it won't tell you 550, 600, 700. If it reaches 500, it'll just print out the word high on the monitor. Okay, it's a little handheld thing. It's about the size of a stopwatch. Okay, and they make them all different shapes and sizes. Okay, normal non-fasting and childhood blood glucose levels range from 80 to 100. Neonates should be above 70. So neonate child or neonate baby should be above 70. The normal BGL for people is 80 to 120. Under 80, they're hypoglycemic. Over 120, they're hyperglycemic. And when they're over 400, then that's when they're in the danger zone. Interventions: reassess the patient with diabetes frequently, every 5 minutes, because they're not going to be stable. For hypoglycemic, conscious patients who can swallow, encourage the patient to take glucose tablets or drink juice containing sugar. You're not authorized to give glucose tablets in the state of Rhode Island. It would just be oral glucose. Okay. Administer the gel preparation or a sugar drink, like I said earlier. Get the oral glucose in their mouth after getting med control's permission. Make sure you administer it correctly. And once it's all gone, the patient is still awake and they still have a gag reflex, get them some fruit juice, okay, and provide rapid transport. Interventions continued. Hypoglycemic, unconscious patients at risk of aspiration. If you have a hypoglycemic patient and they're unconscious, you do not give them anything orally because they don't have a gag reflex. Okay, this person needs an IV of glucose or an IM or intranasal glucagon beyond EMT competencies. Glucagon is a medication that in the state of Rhode Island we are allowed to give as EMTs, but for now, because on a national basis, on a national certification basis, only medics and advanced EMTs are allowed to do it. Rhode Island takes it one step further and they give us a protocol to give it as basics, but don't worry about that now. You're going to learn that when you're out in the field. Right now, glucagon is a medication that only cardiacs, advanced EMTs, and paramedics are allowed to give, according to the national standards. So you're only allowed to give oral glucose, okay, in the state of Rhode Island. When in doubt, consult med control. When in doubt about anything on a call med control. Okay. If you're unable to test blood for a glucose value, perform a thorough assessment of the patient. Contact the hospital to help sort out the signs and symptoms, because things will be going through your head very, very quickly. A lot of the basic signs and symptoms are sort of the same, but there are differences. Okay, someone who's hypoglycemic, they're gonna seem like they're out of it. They're gonna be very lethargic. Where someone who's hyperglycemic, they're not gonna be as much. Someone who's hypoglycemic, low blood sugar, their skin is going to be pale, cool, and clammy, like shock. Okay, they could be going into shock. Somebody who's hyperglycemic, warm or regular skin condition. Okay, coordinate communication and documentation. Patients who refuse transport after oral glucose administration may require more thorough documentation. If you are called to somebody's house because somebody is scared to death, they call 911. They think that there's a problem. That's why they called you. You go there. You examine the patient. It's determined that their BGL is low, so they're a hypoglycemic patient, but they're still somewhat conscious. You give them oral glucose. They start to come out of it. You get some fruit juice into them. They come out of it even more. Okay, great, no problem. My wife's going to make me some breakfast right away. Do everything you possibly can to get that patient to go to the hospital. They need to go to the hospital because if they don't eat right away, they need to eat right away, and they need to give their body time to absorb the food and to break it down and to turn it into glucose. That person will go right back to where they were 20 minutes ago when they called 911 because they're going to be out of it. Okay, they need to go to the hospital. The doctors need to examine them. Do everything you possibly can to get them to go. If you can't get them to go, have your partner try to talk to the patient. If they don't want to listen to your partner, most likely you're going to have police on scene because they usually send police to all EMS calls just to make sure that it's safe for us. If the cops are still on scene, have the officer try to convince the person to go too. Try to convince the spouse or the brother, the son, the sister, the daughter, who's ever with the patient, try to get them to convince the patient to go too. Okay? They need to go. Emergency medical care for diabetic emergencies, 1 of 2. Giving oral glucose, that's what it looks like right there. Okay? It's a 15-gram tube, and you're going to give it to them all. Not all at once, but over a period of a couple of minutes. Okay, it's rapid dissolving gel, or large chewable tablets, or liquid formulation. I've seen the large chewable tablets. They sell them on the outside of the pharmacy. You do not require a prescription to buy those. Usually diabetic patients carry those in their purses or their pockets or their cars. And liquid formulation, I've never seen liquid formulation where somebody can drink liquid glucose other than like soda pop or something really, really like sweet tea or something like that. Oral glucose, contraindications. When do you give and when do you not give? When you don't give it, we've already discussed when you give it. Now the contraindications are when you don't give it, inability to swallow, and they're unconscious. So they do not have a gag reflex. Make sure you're wearing your gloves before putting anything in the patient's mouth. Follow local protocols for glucose administration. You're going to reassess the patient frequently, which is every 5 minutes because they're not stable, and you're going to provide rapid transport to the hospital. The presentation of hypoglycemia. Seizures should be considered very serious. Hypoglycemia is a possible cause for seizures, may indicate a potential life-threatening underlying condition, hypoglycemia, and management of the patient. Altered mental status may be caused of other conditions, hyper or hypoglycemia, may be caused by diabetes complications, could be that they're having a bad reaction to new diabetic medication the person's taking that the doctor just prescribed to them 2 days ago. Okay? And use a mnemonic, AEIOU, and TIPS, TIPS, and manage the patient. Misdiagnosis of neurologic dysfunction. Okay, symptoms mistaken for intoxication. Just because somebody is acting like they're drunk doesn't mean that they're drunk. Just because a person has a sweet smelling breath, like they drank a whole bunch of sweet liquor or something like that, does not mean that the person is an alcoholic. Does not mean that they are drunk. Okay, it may be caused by the diabetes complication. It may be diagnosed by the hypoglycemia. Okay, could be they went to the bar, had a bunch to drink, but they haven't eaten since breakfast this morning. Now it's 9 o'clock at night. Look for emergency medical identification tags on the bracelets tags. It'll say whether they're diabetic or not. Do a BGL on scene. And diabetes and alcoholism can coexist in a patient. A person can be an alcoholic and they can be a diabetic at the same time. But yet they can still have low blood sugar. And that's why they're acting drunk. Okay? Relationship to airway management may not have a gag reflex. If they do not have a gag reflex, that means that they're unconscious. That means you can't put anything in their mouth. Vomit or tongue obstruction may occur. Okay, that's why you keep an eye on the airway. That's why you make it is patent. Make sure you secure that airway. Carefully monitor it. Place the patient in lateral recumbent position if required. Okay, get them on their left side. So if they do vomit, they're not going to aspirate it. Aspirating is when you inhale your vomit, which is disgusting, but it happens a lot. So if you lay them on their left side, if they're going to vomit, it's going to come right out of their mouth, and they're not going to breathe anything in. And make sure you have your suction unit ready to go so you can clear the airway. Okay? Now, that's basically all we're going to talk about when it comes to diabetes. Okay? Now we're going to talk about blood. Hematology. What is hematology? Hematology is the study of blood-related diseases. And as we know, diabetes has everything to do with the blood. Has everything to do with what's floating around in the blood. Okay? Insulin, glucose, glucagon, everything. Okay? So, hematology, hematology is the study of blood-related disorders. Okay? Will we have hematology or blood emergencies? Yes, we will. The three we're going to concentrate on today is going to be sickle cell disease, hemophilia A, and I can never pronounce this correctly. Thrombophilia. Okay? Sickle cell is something I've heard for years, since I've been a little kid. Okay? Sickle cell disease. Okay, first of all, let's go back to blood. What is blood made up of? Blood is made up of four things. Okay? It's made up of red blood cells, white blood cells, plasma, and platelets. And we all know that red blood cells carry the oxygen because there's hemoglobin on the red blood cells, and that's how oxygen gets transported throughout the body because it latches onto the hemoglobin, which is part of the red blood cell. Okay? White blood cells, we know, fight infection in the body. Plasma is the liquid that flows through our blood, is part of our blood that allows the white blood cells, red blood cells, and the platelets to get transported throughout the body. And the platelets are sticky little suckers that help create clots in good times and in bad. So platelets make up about 4 to 7% of our blood volume. Okay, red blood cells make up about 42 to 47% of our total blood volume. White blood cells take up about 0.1 to 0.2% of our blood volume. Now, red blood cells are also known as erythrocytes, and white blood cells are also known as leukocytes. So you've got red blood cells, which are erythrocytes, white blood cells that are also called leukocytes, plasma, and platelets. Okay? The red blood cell, otherwise also known as the erythrocytes, as I said, takes up about 42 to 47% of our blood volume, carries approximately 97% of the oxygen and some carbon throughout our body. So 90% of the oxygen that we use is carried by the red blood cells. Okay? And as you know, when you have the diffusion and perfusion taking place at the cellular level, oxygen and carbon pass each other. Okay? The red blood cell also carries the carbon back to the lungs where we exhale it. Okay? Sickle cell disease affects the red blood cell. Sickle cell disease was identified and labeled in 1910 by a gentleman by the name of Dr. James Henrick. Okay, the red blood cell, the reason why they called it red blood cells, back then they didn't have lawnmowers. They didn't have John Deere tractors that would go out and cut the hay and the corn down. They had sickles. Okay, and the sickle is a half-moon blade that's on that long stick that you see people swinging back and forth from the right to the left or the left to the right. You ever seen the Grim Reaper? You know, the skeleton, the skeleton wrapped in the black robe, and he's got this long thing with a large curved blade on it. That's called a sickle. Okay? The reason why it was called sickle cell disease is because the red blood cells actually look like a sickle. And if you want to, I should have them right here. I'm sorry. There we go. Look at the pink ones. That's a sickle cell right there. Okay? So it's very common. Sickle cell is very common in people who live in what they call the malaria belt. The malaria belt would be down in the continent of Africa, the Caribbean, and down in South America. Okay, sickle cell affects people who have South American ancestry, people from the Caribbean, and people from Africa. Okay. The reason why, I think the only good thing about sickle cell is that the people in those areas, the people who live in what they call the malaria belt, the sickle cell actually protects them against malaria. People who have the sickle cell in their bloodstream are protected against malaria. They won't get sick from it. I don't know why, I don't know how, but that's just what it says. The bad thing about sickle cell is that the shape of it hinders the oxygen binding to the red blood cells. And it also increases the possibility of forming clots because it thickens the blood. And by increasing the chances for clotting, blood clots in the body, they call that vaso-occlusive crisis. Vaso-occlusive crisis is when the sickle cell increases the opportunities for clots in the arteries and the veins. Sickle cell is not with the person their entire life. They have sickle cell bouts or experiences. The sickle cell only lives for about 100 to 120 days. So that's like that's like anywhere between 3 to 4 months. So this person will be in agony because it also causes pain as well. Because the reason why it causes pain is because when it hinders the oxygen latching onto the red blood cells, that means that the SpO2, your oxygen saturation, is lower in your body. And that means that your tissues and your muscles and your cells in your body are going to be starving for oxygen. And they're not getting the level that they should be. So they're going to start getting mad and they're going to start giving you pain in the joints. You're going to have respiratory distress. You're going to have people have difficulty breathing. Let's go back here. Okay, it's just sickle cell disease. An inherited disorder affects the red blood cells. Predominantly people of African, Caribbean, or South American ancestry. People with sickle cell disease have misshapen red blood cells that lead to dysfunction in oxygen binding and unintentional clot formation. Clots may result in a blockage known as vaso-occlusive crisis, and they can cause hypoxia, which is poor oxygen saturation, pain because the cells are not getting the oxygen that they're supposed to get, and as a result, that pain is caused by tissue dying or being injured, and that's going to cause damage to the organs. Sickle cells have a short lifespan, like I said. What did I say? 3 to 4 months, 110 to 120 days. Results in more cellular waste products, contributing to sludging in the blood. That's right. So while the person has the sickle cells active in their body, it's going to create more cellular waste than normal. And in the process of creating that cellular waste, that actually makes the blood a little sludgy, a little thicker. And that's where the increase in clotting comes from. Okay? Some of the complications or the problems that accompany sickle cell are anemia, gallstones, jaundice, dysfunction of the spleen, and vascular occlusion with ischemia. Ischemia is tissue death, as you remember. Okay, so vascular occlusion means closing. So arteries and veins are going to start shrinking, not dilating. They're going to start constricting, and in doing so, reducing the blood flow. So that means the body's not going to get sufficient perfusion or diffusion, and you're going to have ischemia, which is tissue death. Okay. Sickle cell disease, many of these complications are very painful and potentially life-threatening. Okay. Clotting disorders of hemophilia. Okay. You're going to have people out there who are going to tell you, I'm a hemophiliac. And you say to yourself, well, what's a hemophiliac? Hemophiliac is when a person has difficulty clotting. You may cut your finger on a piece of paper, or you're cutting a strawberry and you nick your finger and you bleed a little bit. You put it, you wash the cut, and you push some pressure on it. About 30 seconds, it stops bleeding. Somebody who's a hemophiliac, that same cut would take them like 3 hours to get it to stop bleeding, because the clotting factor of the platelets is inhibited, so it takes a lot longer for the person to stop bleeding. Hemophilia is usually affects more males than women. Decreased ability to create a clot after an injury, which can be life-threatening. Patients typically have intravenous factor, I think that's factor 8 replacement infusions, which help the blood clots, not take place. And they usually have that close at hand. They usually has close by, so you can get quick access to it. Clotting disorders, thrombophilia, disorders in the body's ability to maintain the smooth flow of blood through the venous and arterial systems. Okay, so the blood is not flowing as smoothly through the veins and arteries as it should. Okay, concentration of particular elements in the blood creates clogging or blockage issues. General term for many conditions that result in blood clotting more easily than normal, and clots can spontaneously develop in the blood of a patient. There's something that we call DVTs, deep vein thrombosis. It's a common medical problem in sedentary patients and in patients who have had recent injury or surgery. Sedentary, what does that mean? Is that the person sits on their butt all day and they watch TV all day. Or they're not as active. They don't get up and around. When you get up and around, you walk around, inside or outside, you're circulating the blood throughout your body a little bit quicker. Your BP goes up, your blood pressure goes up, which is good. You're exercising. Even if it's walking, that's exercise. Whereas those people who have sedentary lifestyles, they don't walk that much. They barely exercise. They barely get up and walk around. It could be that they're bedridden due to a medical situation. They can't get out of bed. They can't walk. It could be that they're stuck to a wheelchair for the rest of their life because they lost both of their lower feet, or they lost both of their foot to diabetes. They had the toes and the lower feet cut off. Okay, at the phalanges. So DVT is what they call deep vein thrombosis. It actually it's a clot that forms in your lower extremities, and then it breaks off and it goes up into your lungs and becomes a pulmonary embolism. Okay, common medical problems in sedentary patients and in patients who have had recent injury or surgery. It's very common for someone 20, 30 years ago when you had a knee replacement or hip replacement, you were stuck in bed for 2 or 3 weeks. Now you have your knee replacement on a Monday morning. By Monday night or first thing Tuesday morning, they have you up walking around. They make you get up. They have physical therapy. They have the PT department come in, and they want you to start exercising as much as possible. Number one, to get the blood flowing to the surgical site, and getting the more blood flow, the better, because the more blood flow, the more fresh blood, the more oxygen, the more mineral and vitamins and nutrients are getting to the injury site or the surgical site, and the more of that stuff to that type of an area will help it heal a lot quicker. And it's also helping the possibility of clots forming decrease. Okay? Let's see. Methods designed to prevent blood clot formation include blood thinning medications, compression stockings, and mechanical devices. Compression stockings you might see elderly men wearing, or sometimes women. It's a man, he's wearing like a calf-high sock, and it's really thin, and it's squeezing his legs. That actually aids. By doing that, actually aids in the circulation of blood down to the lower extremities. Blood thinning medications, very common for people who have had heart attacks or strokes before in the past. Clotting disorders, DVT continued, risk factors, treatment, anticoagulation therapy, which would be a medication. Oral medications typically administered for at least 3 months after the diagnosis of a DVT. A clot from a DVT can travel to the patient's lower extremity to the lung, causing a pulmonary embolism. Scene size up. Most sickle cell patients will have had a crisis before. They'll know what's going on, and they can tell exactly what to wear and what to do. Make sure you have your BSI on, and consider ALS support. Consider an MOI, mechanism of injury, NOI, nature of illness. Okay. Remember, a trauma may have also occurred. Perform cervical spine immobilization if necessary. Okay, that's your scene size up. Then you get your primary assessment, which it starts with form general impression. The perform cervical spinal mobilization, that's in your scene size up. That's the last thing in your scene size up. Then your primary assessment starts with forming a general impression. Okay, determine LOC, level of consciousness, level of responsiveness. Are they AOC times 4? Are they alert, oriented consciousness of person, place, and time? You can start looking for life threats at this time. You can start looking at the airway. Is it patent? Yes or no? Are they breathing correctly? Yes or no? Same thing with the other patient we were talking about. Are they breathing too slow or too fast? If they are, what do you do? Is the airway secure? Is it patent? If not, then what do? Do you use an OPA or NPA? You know how to measure for it, blah, 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 and all that other stuff, okay? High flow oxygen at 10 to 15 liters per minute in a non-rebreathing mask. That's high flow, that's 80-90% oxygen saturation. And a sickle cell crisis patients may have increased respirations or signs of pneumonia. Circulation, check the pulse, the skin color, temperature, condition. Sickle cell patients increased heart rate. Hemophilia, be alert for signs of acute blood loss, note bleeding of unknown origin, and be alert for signs of hypoxia. Okay? Because they're a hemophilia patient, if they're bleeding, they're going to be bleeding a lot. And it's going to take a lot longer, a lot more energy on your part to get the bleed to stop. Okay? So you have a possibility the person going into shock. What type of shock could the person be going into if they're losing a lot of blood? That's called hypovolemic shock. Okay? Make a transport decision. Scoop and screw, stay in play. Investigate the chief complaint. What's going on? Do your history. Do your sample, your OPQRST. You know what to do there. Okay, ask about, is the pain isolated, a single location, or felt throughout the body? Visual disturbances, you having problems seeing, nausea, vomiting, or abdominal cramping, and chest pain or shortness of breath. You guys know all the questions to do. Sample, OPQRST. Secondary assessment. Secondary assessment is when you concentrate on the affected body part or body system. Okay? Use the AVPU. Take your vital signs, blood pressure, pulse, respirations, neural check. Don't forget the FAST, face, arm, speech, and time. You're going to do BGL on this patient as well. Okay? Even though one little drop's not going to do it, one little drop's going to do it, but instead of 30 seconds having that patient squeeze their finger, they have to squeeze it the entire time on the way to the hospital. It's still going to bleed a little bit. Okay? Get an SpO2 reading on that patient as well. Reassess a patient every 5 minutes because they are not stable. Evaluate your interventions and adjust to change where necessary. Administer supplemental O2 if you need it and if you haven't already. And call the hospital ahead of time, tell them what you've got coming on, and prepare your report to give to the doctor. Okay? Emergency medical care for hematologic disorders, mainly supportive and symptomatic. Patients with inadequate breathing or altered mental status, administer high flow O2, non-rebreather, place in a position of comfort, transport rapidly to the hospital. What does that remind you of? High flow O2, place in position of comfort, rapid transport to the hospital, and keep them warm with a blanket. You're treating them for shock. Okay? So, okay, we're at the review. So that takes care of everything we were talking about, everything we're going to talk about in the chapter. That completes the chapter. So we're going to do a quick review, or the chapter review at the end, and then that'll be it. So question number 1, type 1 diabetes is a condition in which what? A, too much insulin is produced. B, glucose utilization is impaired. C, too much glucose enters the cell. Or D, the body does not produce enough glucose. Answer would be B, glucose utilization is impaired. Type 1 diabetes is a disease in which the pancreas fails to produce enough insulin or produces none at all because our system is creating antibodies to hinder the pancreas from doing its job. Insulin is a hormone that promotes the uptake of sugar from the bloodstream and into the cells. Without insulin, glucose utilization is impaired because it cannot enter the cell. Excuse me. Question number 2. A 45-year-old man with type 1 diabetes is found unresponsive. Which of the following questions is most important to ask his wife? A, did he take his insulin today? B, how long has he been a diabetic? C, has he seen his physician recently? Or D, what kind of insulin does he take? Answer would be A. All these questions are important to ask the spouse of an unconscious diabetic patient. However, it is critical to ask if the patient took their insulin. Okay? This is where this will help you differentiate between hypoglycemic crisis from the hyperglycemic crisis. For example, if the patient took his insulin and did not eat, or accidentally took too much insulin, you should suspect hypoglycemia. If the patient did not take his insulin, then you should suspect hyperglycemia. Number 3, a diabetic patient presents with a BGL of 310 and severe dehydration. The patient's dehydration is a result of what? excretion of glucose and water from the kidneys. B, a deficiency of insulin that causes internal fluid loss. C, an infection that often accompanies hyperglycemia. We never talked about infections. Or D, an inability to produce energy because of the insulin depletion. It would be A. In severe hyperglycemia, the kidneys excrete excessive glucose levels from the body. The process requires a large amount of water to accomplish. Therefore, water is excreted with the glucose, resulting in dehydration. Question number 4. Which combination of factors would most likely cause a hypoglycemic crisis in a diabetic patient? Eating a meal and taking the insulin, skipping a meal and taking the insulin, eating a meal and not taking the insulin, or skipping a meal and not taking the insulin? Tricky answers. Which combination of factors would most likely cause a hypoglycemic crisis? It would be D. No. I'm sorry, it's B. Skipping a meal and taking the insulin. You skip a meal, you don't eat, and then you take the insulin. The insulin is telling the body, okay, eat up all the sugar you want to. Here are the keys. I'm going to unlock the doors of all the cells. Eat up, guys. And you're depleting your body of all the stored glucose. And because you didn't eat, you're not replacing the sugar that your body's eating. So that's why it's B. The combination that would most likely cause a hypoglycemic crisis is skipping a meal and taking insulin. The patient would use up all available glucose in the bloodstream and become hypoglycemic. Left untreated, hypoglycemic crisis may cause permanent brain damage and or even death. Number 5. A 19-year-old diabetic was found unresponsive on the couch by his roommate. After confirming that the patient is unresponsive, you should what? Suction his oropharynx, mainly open his airway, administer high-flow O2, or begin assisting his ventilations. Remember the basics. You would open his airway. Okay? ABCs, airway, breathing, circulation. Open that airway. Next one. What breathing pattern would you most likely encounter in a patient with diabetic ketone acidosis? Remember, that's diabetes 1. And it's because the DKA, the diabetic ketone acidosis, their blood sugar level is probably over 400. So what breathing pattern would you most likely encounter in a patient with diabetic ketone acidosis? Again, trying to get rid of the ketones because the body's burning body fat. Acid waste is the byproduct. Would it be slow and shallow and irregular, rapid and deep, or slow and irregular? C. Kussmaul respirations, a rapid and deep breathing pattern seen in patients with diabetic ketone acidosis, indicates that the body is attempting to eliminate ketones via the respiratory system. A fruity or acetone breath odor is usually present in patients with Kussmaul respirations. A woman has called EMS because her 12-year-old son, who has been experiencing excessive urination, thirst, and hunger for the past 36 hours, has an altered mental status and is breathing fast. You should be most suspicious of what? Low blood sugar, hypoglycemia crisis, or hyperglycemia crisis. A woman called EMS because her 12-year-old son, who has been experiencing excessive urination, thirst, and hunger for the past 36 hours, has an altered mental status and is breathing fast. D. Hyperglycemic crisis. The child experiencing a hyperglycemic crisis secondary to severe hyperglycemia. Okay, hyperglycemic crisis is characterized by a slow onset and excessive urination. If you go back, she said for the past 36 hours, that's a day and a half. Okay, that was the key right there. It took a long time. Okay, that just goes, and this is a good example. It can take a day and a half for hyperglycemia to show up, but it can take just hours, 3 or 4 hours or 5 hours for hypoglycemic. Hypoglycemia happens very, very quickly. Hyperglycemic crisis is characterized by a slow onset and excessive urination, which is polyuria or polyura, thirst, which is polydyspia, and hunger, polyphagia. Other signs include rapid, deep breathing, Okay, rapid, deep breathing, Kussmaul respirations, with a fruity or acetone odor. A rapid, thready pulse, and altered mental status. Okay. Number 7. A woman called EMS because her 12-year-old... I'm sorry. Number 8. If the cells do not receive glucose, they will begin to metabolize what? Fat, acid, sugar, or ketones. If the cells do not receive glucose, which is a fuel, they will begin to metabolize what? Fat. Start burning fat, creating acid waste, which is called ketones, and then your body is going to start having fruity breath, and your body's going to say start breathing fast and deep, and those are called Kussmaul respirations. Number 9. In contrast to hyperglycemic crisis, a hypoglycemic crisis is A, rarely presents with seizures, B, presents over a period of hours to days, C, should not routinely be treated with glucose, or D, usually responds immediately after treatment. D, hypoglycemic crisis usually responds immediately following treatment with glucose. Patients with hyperglycemic crisis generally respond to treatment gradually within 6 to 12 hours following the appropriate treatment. Seizures can occur with both hyperglycemic and hypoglycemic crises, but are more common in patients with hypoglycemic crises. Number 10. There's 15 questions here, guys. 14 questions, I'm sorry. Patients with diabetic ketone acidosis experience polydysphia because they are dehydrated secondary to excessive urination. B, the cells of the body are starved due to lack of glucose. C, fatty acids are being metabolized at the cellular level. Or hyperglycemia usually causes severe internal water loss. Patients with diabetic ketone experience polydysphia because, remember what polydysphia is? A, severe hyperglycemia, which leads to diabetic ketone acidosis, causes the body to excrete large amounts of glucose and water. As a result, the patient becomes severely dehydrated, which leads to excessive thirst. Polydipsia. Polydipsia. Okay? Number 11. When dealing with hematologic disorders, the EMT must be familiar with the composition of blood. Which of the following is considered a hematologic disease? Sickle cell, hemophilia, Lou Gehrig's disease, or both A and B? We didn't talk about Lou Gehrig's disease. We talked about hemophilia, and we talked about sickle cell. So I would say it's D. Hematology is a study of prevention of blood-related diseases such as sickle cell diseases and hemophilia. Hemophilia being inability to clot. Number 12. What are the two main components of blood? Remember I talked about the red blood cell, the white blood cell, the platelets, and the plasma. And the red blood cell is also known as what? And the white blood cell is also known as what? Erythrocytes are in hemoglobin, cells in plasma, leukocytes, and white blood cells are platelets. Answer is B. The blood is made up of two components, cells and plasma. Okay, honestly, that was a tricky question because you got the red blood cells, the white blood cells, the platelets, and the plasma. Okay, the two main components of blood, and I apologize, I did not discuss that with you guys. Blood is made up of 4 different things, but the two main components, if you take a look at it, you've got the plasma, okay, and then in the plasma, you've got the cells. What kind of cells? You've got red blood cells, white blood cells, and platelets. Okay, so the two main components of blood is made up of 4 components. You know that, red blood cell, white blood cell, plasma, and platelets. But the two main components is the plasma, and then is the cells. And that is made up of the 3 other things, the red blood cell, white blood cell, and platelets. The blood is made up of 2 main components, cells and plasma. The cells in the blood include red blood cells, white blood cells, and platelets. These cells are suspended in a straw-colored fluid called plasma. Plasma is like a really, really light-colored yellow. Question number 13. The assessment of a patient with a hematologic disorder is the same as it is with all other patients an EMT will encounter. In addition to obtaining a sample history, EMT should ask which of the following questions. A. Have you had a crisis before? B. When was the last time you had a crisis? C. How did your crisis resolve? Or D. All of the above? I would say it's D. All the above. Sample is a mnemonic used to take history of all patients. In addition to asking the sample, EMT should also ask about past crises, such as past medical history, and you have chest pain. Oh, you had a heart attack 3 years ago? Anything else? Oh, you had a heart attack before that, a year before that? Anything else? Oh, you had open heart surgery 3 months ago. Okay. Last but not least, question number 14. Which one of the following is not an appropriate treatment for EMTs to provide a patient who has a hematologic disorder? Which of the following is not an appropriate treatment for an EMT to give to a patient who has a hematologic disorder? Would you give them analgesics for pain? Would you support of the symptoms? Would you give high-flow O2 therapy, 12 to 15 liters per minute? It should be 10 to 15. And or would you give them rapid transport? Which of the following is not an appropriate treatment? Would you give them rapid transport? Yes. Would you give them high-flow O2? Yes. Would you support and treat the symptoms? Yes. Would you give them analgesics for pain? You don't give analgesics. So the answer is A. Although analgesics would benefit a patient suffering from a hematologic disorder, the administration of such medications is not in the scope of practice for the EMT. ALS providers would have to be present to provide this emergency care. Okay. Other than that, that completes the chapter 19. Okay. I hope you guys learned something. Sorry about that. Didn't mean to go backwards. I hope you guys all have a good day. Take care of yourselves. Please be safe. Hopefully we'll be able to start reopening the state in the middle of next month like the governor wants to. But keep that but in the meantime, please keep your 6-foot distance. Wear your masks when you go out of the house. Be smart about it. Take care of yourselves and your family and your friends. Nothing's more important than family. So take care of yourselves. Look forward to meeting you guys one of these days, hopefully. And have a great day. Take care. Bye-bye.